Earlier in this course, I shared with you comments by Dr. Steven Schroeder of the University of California, San Francisco School of Medicine, in which he estimated that 40% of premature deaths in the United States are directly attributable to patterns of behavior, chief among them smoking, obesity, and inactivity and alcohol use. As Schroeder argued, the single greatest opportunity to improve health and reduce premature deaths lies in personal behavior. We know that reducing deaths and improving well-being is not as simple as encouraging someone to stop smoking. Individuals develop many of their behavioral patterns in childhood and adolescence, with their inherited genetic traits combining with the impacts of the social and psychological environment in which the child grows up to influence that behavior. A growing body of research has also shown that, in addition to affecting behavior directly, factors in the social and psychological environment of infants and children can also change the way in which genetic information is expressed, a process known as epigenomic imprinting that can lead to measurable differences in neural structure and physiologic functioning. We have repeatedly seen that the quality and level of education one attains, beginning in preschool and kindergarten and continuing on to college and beyond, plays a major role in affecting adult behaviors of the type Dr. Schroeder described. However, that educational attainment is itself largely dependent on a range of behaviors developed in childhood, especially behaviors exhibited in the early years of school. In 1995, researchers from the Federal Centers for Disease Control and Prevention in Atlanta and from the Kaiser Permanente healthcare system in San Diego began the Adverse Childhood Experiences Study, often referred to simply as the ACE study, to assess the long-term impact of abuse and household dysfunction experienced during childhood on well-being as adults. This figure from the ACE study website describes graphically the potentially lifelong effects of ACEs on social, emotional, and cognitive functioning. These functional changes are often associated with alterations in neurologic structure, in particular in the hippocampus and amygdala and associated cortical areas. During childhood and adolescence, these changes increase the likelihood that individuals experiencing ACEs will adopt behaviors that put their current and future health at risk. These behaviors include such things as smoking, diet, and sexual activity, but in particular also include a child's response to the educational challenges and opportunities he or she confronts. This series of relationships experienced throughout the life course is shown here on a vertical timeline. These relationships are essentially the same as the series of relationships we developed in our previous slide that was shown with a horizontal timeline. The Federal Centers for Disease Control and Prevention have described the ACE study as, quote, one of the largest investigations ever conducted to assess associations between childhood maltreatment and later life health and well-being, unquote. As the agency charged with protecting the health of the American people in the long term, the CDC has determined that in order to improve health and well-being, quote, it is critical to understand how some of the worst health and social problems in our nation can arise as a consequence of adverse childhood experiences, unquote. In 2010, officials from the World Health Organization in Geneva met with representatives from the U.S. CDC, as well as the researchers from the ACE study in San Diego, in a collaborative effort to initiate a global surveillance program to gauge the incidence and lifelong effect of ACEs. Addressing the issue in a global context, the report of this meeting confirmed that by far the largest proportion of the burden of disease due to ACEs arises from the cumulative effect of chronic exposure to multiple adversities whose lifelong consequences may often start to become apparent only after many years after exposure. In one of the first publications coming from the ACE study, in 1998, Folletti and colleagues reported on their survey of 9,500 adults with a mean age of 56 that was conducted as part of their regular health assessment at Kaiser Permanente. Using a standardized assessment tool, they asked these adults to report their childhood exposure to ACEs. They then compared the frequency of the reported ACEs with their health status as an adult. They were able to confirm that those who reported having experienced a higher level of ACEs as a child were, as adults, more likely to suffer from alcoholism, drug abuse, depression, smoking, obesity, heart disease, cancer, chronic lung disease, as well as liver disease. It was based on data such as these that the ACE study was able to develop its model of causation illustrated in this figure. This chain of causal associations, beginning in childhood and continuing through adolescence into adulthood, brings up the question of when in this causal chain is it best to intervene so as to improve the level of educational attainment and prevent the adoption of health risk behaviors. Might it be best to focus interventions on the time of birth before a child has experienced directly any adverse experiences? This is the question that has been addressed in a study that began several decades ago, known as the Carolina Abecedarian Project. Beginning in 1972, researchers enrolled the families of 104 newborn infants, all living in the Chapel Hill area of North Carolina. The families were identified as high risk based on a series of criteria that included meeting federal poverty guidelines, the age and educational level of the mother, and the family structure. 75% of the families were single-parent households. Based on these criteria and the region from which the families were recruited, 98% of the families in the study were African American, although race was not used as an explicit selection criterion. The children were randomized at birth, with half receiving intensive social and educational support beginning at birth. This intervention included full-time, year-round professional daycare for 5 days per week from birth to age 5. The program in the daycare program included interventions to teach basic cognitive and social skills, as well as frequent interaction that emphasized the development of language skills. Those children randomized to the control group received no specialized intervention, although some children did participate in existing daycare programs in the area. Families from both groups were offered social support services that they could call on if needed. The intervention ended when the children reached age 5 and were ready to enter school. They then followed these children into adulthood, measuring at various ages the differences in outcomes of the children receiving the intervention as compared to those who did not. For example, at age 3 to age 5, the study subjects had greater cognitive ability, as measured by our standard IQ test. At age 8 and age 15, the study subjects continued to have greater cognitive ability, and they had developed greater reading and math ability. At age 21, the study subjects continued to have greater cognitive and academic ability. They also had better educational attainment overall, and they showed evidence of better social adjustment based on a range of behaviors, as shown here. By their mid-30s, the study subjects also had evidence of better physical health based on a range of physiologic risk markers. The study provides clear evidence that interventions beginning at birth for children identified as high risk for experiencing adverse experiences during childhood can change behaviors, improve educational outcomes, and improve lifelong well-being. Consistent with the findings of the ABCDarian study, a range of interventions nationally involve a home visitor with families with newborn infants and young children. This will often be a nurse or other trained professional who begins meeting with high-risk parents at home to provide education, support, and counseling with special emphasis on parenting skills. Some of these programs are also linked to preschool programs. In 2009, Howard and Brooks Gunn reviewed the outcomes from a range of these home visitor programs. The authors were able to conclude that, quote, evidence is mounting that these programs can positively alter parenting practices and, to a lesser extent, children's cognitive development, unquote. The authors suggested that the mixed outcomes in affecting children's cognitive development may have been because few of these home visitor programs included high-quality daycare as well that emphasized language and cognitive development. From these and other studies, the American Academy of Pediatrics has recommended to pediatricians and other professionals who provide care to potentially high-risk children that, quote, home visiting programs offer a mechanism for ensuring that at-risk families have social support, linkage with public and private community services, and ongoing health, developmental, and safety education, unquote. In the context of a national emphasis on redesigning the pediatric care process, the APA has also emphasized that when these services are part of a system of high-quality, well-child care linked or integrated with the pediatric medical home, they have the potential to mitigate health and developmental outcome disparities. While the evidence is strong in support of early intervention for those children at risk of adverse experiences during childhood, this does not suggest that early childhood is the only time at which interventions will be effective. There continue to be a range of programs that target children in elementary school and middle school, including new ways of training teachers to be aware of the potential causes of what may appear to be combative or disruptive behavior on the part of the students who have experienced frequent adverse experiences at home or in their community, as well as the optimal approach to teaching these children so that the children can improve both their cognitive skills and their behavioral patterns. There also continue to be valuable programs that target children in high school who appear to be at risk of not completing high school and not continuing on to college. All these programs have the potential to improve patterns of behavior as well as associated well-being. It will be important to continue the ongoing efforts to identify which of these interventions hold the most promise, and then to invest society's resources in these best options.